One of the things that we want to understand is what we like to accomplish when we get a patient in and we start doing some work on their back, mostly in here, in terms of the massage. One of the things we want is a general sort of relaxation. We also want to bring healing energy and comfort and attention to an area that is in pain. For example, a low back that is not happy. The patient often doesn't think about it or tries to forget the painful area, and what we want to do in here, we want to bring attention back to it because we want to actually help it and try to bring healing to it as much as we can, and also figure out what causes the pain. And so for that we need the patient to not be tuned out with the pain, but sort of be tuned in with the pain in a format that they can and they feel comfortable with doing. Another thing that we want to accomplish with working the muscles is also functionally improving the muscles. We want to give it relaxation in the muscle fibers. We work some trigger points, but we also want to try to decrease the adhesions that are created in between the muscle fibers. We get those adhesions developed when we have a painful area. The body at that point in that area is inflamed. That creates heat. Heat creates more activity and creates the production of more collagen fibers in the area, and that glues muscle fibers together. And so we also want to sort of decrease those adhesions to have the muscle fibers work more individually and work better to support that body and the area that is in pain. Everybody's perception of pain and of what's going on in the body, also the pressure that we apply, is different. So one of the things as a therapist that we need to be very aware and in tune in is that we try to approach the body where it is at. So if this is a body that is really stiff and really tight because there's a lot of pain and the muscle pattern is extremely guarded, we want to be very gentle and very slow and essentially view the muscle or the back as a little child and tell it that it's okay to trust before we try to tell it what to do. So we want to take ourselves sort of out of it and not try to impose our own feelings onto a muscle, and our will, I should say, onto a muscle. We want to be a little bit more passive in that respect and slow down and open up and check in with the area. When it comes to applying the force or what we do, that means we want to initially just sort of get a global read and an okay and a check-in. Most of what we do in here is back related issues. So generally speaking, we work around the spine of the back and we don't work in the extremities. Sometimes we do work in the extremities, but mostly it's low back, mid-upper back, and then also in the neck. So for a large portion of the time, we're going to be face down. I try to spend about 10 minutes on the patient doing this sort of work and check-in. The massage is mostly done over clothing, unless we're going to go deep in a trigger point there and a specific muscle group that we will identify as being a pain-producing area. Then in here we're going to apply more lotion and work it much more specifically. When the patient comes in, initially, it is very important to me to help them again check in with their body. So I want to take myself out of the equation. I want to greet them. I want to ask them, you know, how are things going? How is your back doing? What is this, you know, how is it progressing? Is it getting any worse? Is it getting any better? What are sort of the things that you feel as a patient harm it or make it feel good? It's sort of also, I'd like to focus in this period on the good of what makes your back feel good. What are the positives? What are the wins? Is this really working for you, what we're doing in here? Working it with the massage, with the chiropractic and so forth, with the laser. We want to have them tune in. We want to have the patient have an opportunity to share. Also an opportunity to vent. If they are unhappy with what we're doing in here, great, ask them. We want to know if what we're doing works for them or not. Because A, if it doesn't, there's some things we can shift and make the experience more pleasant, or maybe they're not the right place and we can help them find something that works better for them. It is not an ego trip, it is not a statement about us doing a good job or not, if they're not, if what we do doesn't work for them. So we just let the patient talk a little bit. We don't have to take too many notes on that. One of the things that's good to indicate is, yeah, what makes something worse? What makes something better? What are the things that are working for? When we look at the anatomy first, which is sort of a beginning point, I would think. I have a skeleton here, or a spine at least, that I'm laying over. We have a pelvis down here, and the pelvic crest is approximately right here. Then we have a sacrum, and we have a spine going up, and then coming up with the spinous processes in the middle. The spinous processes, these bumps, are the ones that are most superficial to the skin, so those are most pointy. We do not want to cross that area with either our elbow or our thumb or our knuckles, whatever we use to work the spine. We talked about not crossing the spine itself with an elbow or with a thumb. Whenever we have bone that is close to the surface, to the skin, and we push too much on it, that hurts. When we look at the muscles that are attached to this spine, this skeleton here, the deepest muscle layers are little small muscles that go from transverse process to transverse process, from spinous process to spinous process, from spinous process to transverse process, and some other ones. Those muscles we're never going to touch. They're too deep. We're going to put force on them, but we're really never going to do that much with them. We do more with them when we actually start moving the spine around. The next layer above that is a layer that is much thicker, and that is on both sides of the spine, and it goes all the way up into the neck. That layer is what we're going to work mostly. That layer is very, very important in terms of the stability of the spine. Very often that is a muscle layer that is weak in people that have pain in the spine, and it's a neurological weak, meaning the body is hurt and the brain says, oh, let's not use that muscle anymore because if we use it, it hurts, and so we stop using that muscle. And so what the body will do, neurological, will start using the more superficial muscle, which is right on the surface, and that is called the erector spinae muscle. And those muscles are broad muscles. They're pretty thin, and they go all the way up the spine, and they also go and fan out into the rib areas. And that muscle group is not designed to stabilize the spine. That muscle group is designed to move the spine to the side, for example, to side bend it, or to turn and rotate it to one side or another. When we look at the low back, we definitely going to work the paraspinal muscles. Paraspinal means they're on both sides of the spine. So now we're going to go to the superficial layer, which were the erector spinae, as well as the second layer, which is the stabilizing layer of the spine. And that's really what we want. But we're going to go up and down on both sides of the spine. On the bottom part of the back, we also have the crest, and we have muscles that are right attached to the crest. They're known as the quadratus lumborum on both sides, and those are also very important muscles to work and to have the patient feel better. Up in the upper back, we'll end up having more of a trapezius piece, which is this muscle in here, besides the paraspinal muscles that we go lateral up here. In the neck, we're going to do that on a different session because we're going to do that face up when we work that. Sometimes when the pain is more in the butt area, we also want to bring some glute work and some piriformis work with it, and I'll go through some of the moves that we can do that we can work those muscles with.